So, well, you are going to fire the gun, if you don't mind.
Okay, let's
You
try
will
to share.
be the first speaker. This is okay for you?
It's okay
Are
for
you
me.
ready?
I am ready.
Great. So,
Can you
for
see my slides?
yes, if you allow me, let me introduce yourself to the audience.
Okay.
Catherine is Associate Professor of Medicine of Harvard Medicine School. So this is just to start with, is a very good accolade. She is the chair of a U.S. Rowing Medical and Sports Science Committee, medical director of Female Athlete Program in the Division of Sports of the Medicine Boston Children's Hospital. So it's a very impressive affiliations, and she's a very well-renowned expert in the topic that she is going to talk now to us, the relative energy deficiency in sports and other risk factors for chronic stress injuries. So without further ado, Catherine, the floor is yours.
Okay, so my disclosures, basically, I have some grant support from Joe and Clara Tsai and the Nike Foundation. I'm a paid consultant for Gatorade and the Sports Science Institute, for Hologic and the U.S. Olympic and Paralympic Committee. And I'm part of the REDS working group for the International Olympic Committee. And so I will say we have been very busy this year in the last couple of years because we are putting out a British Journal of Sports Medicine special edition that will have quite a few papers talking about our new approach to REDS. So let's just start with what bone stress injuries are. And we have other experts on this call for sure who know this topic very well, who are going to talk about this a little bit more in detail. But a bone stress injury results from the inability of a generally normal bone to tolerate repetitive loading, leading to localized bone microdamage, weakness, and pain. And so this is kind of a busy slide, just demonstrating that when you have this normal or compromised bone, you get increased repetitive loading, and that leads to bone microdamage. So you get these little cracks. And then normally what would happen is you have osteoblasts and osteoclasts working together where there's this damage and this repair going back and forth. But with various cell signaling, there gets to be a tipping of the scale. And so we actually end up getting a little bit more bone resorption. The bone isn't able to really keep up. And so then you get more of a crack in the bone. And so you get this bone stress injury. So why do we call it a bone stress injury? Well, we really want to make sure that we're differentiating between repetitive loading that distinguishes a bone stress injury from insufficiency type injuries. So insufficiency type injuries occur with aging typically, or with disease. Yet sometimes our athletes share some of the similar phenotypes of compromised generalized bone health. So if somebody has weaker bones because they have a poor hormonal milieu, for example, a female athlete who has poor menstrual cycles or is lacking menstrual cycles, she's going to have compromised bone health. So when we talk about bone stress terminology, the reason we focus on BSI is because stress fractures have this discernible fracture line on imaging. So here's an x-ray where you can see that dreaded black line, but that's only in about 20% of our athletes who present with a bone stress injury. So the other 80% have really stress reactions. And that's why we like to grade these, because we know a stress reaction can often become a full-on bone stress fracture. But a bone stress injury that is a stress reaction won't necessarily show up. Usually we won't see anything on that x-ray. And so here, these are the others that are showing up in the MRIs: an altered signal intensity within the marrow, the endosteum, or the periosteum. And so here's a grading system that I prefer. There are a few out there. You can look at some papers to see some of the other grading systems, but I'm a fan of the Fredrickson grading system, and a lot of us use this. So this is really saying grade 0 through 4, and then you have 4A and 4B. So grade 0 is just a normal bone. Grade 1 is basically periosteal edema only. Grade 2, you have this mild bone marrow edema seen on T2 weighted images or in STIR images. Grade 3, you're going to get moderate bone marrow edema seen on both T2 weighted images and T1 weighted images. Grade 4A, you have cortical signal abnormality that's non-linear in morphology. And then grade 4B, you really see that fracture. So Sometimes you can correlate this with return to sport. There's that mean age, and we have a paper out that discusses that. Again, our next two speakers will talk about that a little bit more. But there are things that can delay that return to sport even more. And one of those things is relative energy deficiency. So to talk about bone health in general, I think it's really important to talk about peak bone mass. And peak bone mass attained during childhood and adolescence is a major determinant of bone mass and fracture risk later in life. So we know that we build about 90% of our peak bone mass by the age of 18. Up to 36% of adult total bone mineral content is acquired during the 4 years surrounding peak height velocity. So the 2 years before that growth spurt in height and the 2 years after are really the time that a lot of bone is laid down. And if a young adult's bone mineral density is just 10% higher than the mean, it may decrease fracture risk and delay the age of crossing the osteoporosis threshold by 13 years. So I like to think of osteoporosis as a childhood disease because we can really try to prevent it during childhood. So when we talk about bone building, duration, and timing, studies suggest that at least 7 months of impact exercise is essential to induce a measurable change in bone mass in children. So pre and early puberty are the times when the skeleton's response to loading is optimal. So here's when we want kids to be very active in sports and to be doing all that loading. And girls who begin strenuous exercise actually before menarche starts gain twice as much bone mineral content as girls who begin after puberty. So childhood is a really important time. Puberty is a really important time. And then we have to keep in mind, though, that it's a little bit of a tricky time because the age of peak height velocity occurs a little bit before that total bone mineral content velocity. So there's a little bit of a delay in when that bone is getting laid down. I said it was before the peak height velocity and after, but that peak of when you're getting that bone mineralization is a little bit later. So what does that mean? Well, basically, boys have their puberty a little bit later than girls. And then for both, they have this peak height, they have this big growth spurt, and the bones lengthen before they are getting really mineralized. So they have this time when they have increased cortical porosity. This is also a time when they have increased sports volume, they have increased fragility, and then they've increased fracture susceptibility. So our adolescents are already at more risk for getting bone stress injuries around that time of puberty. So when we talk about that, the other things we have to consider about peak bone mass are just the different things that come into play. You know, we can blame our parents for 60 to 80% of it. Genetics are a huge component, but then the mechanical forces we just discussed, then hormones. So what's going on with puberty? Is puberty delayed? Does somebody lose their period? And then nutrition. And so we'll talk about how those all come into play. Finally, there's other risk factors, and we don't need to get into those as much today. So this brings us to low energy availability. And low energy availability really is based on this equation. So this idea that dietary energy intake minus exercise energy expenditure normalized to fat-free mass equals energy availability. And energy availability is what we have left over for our body to function after all of the other things we're doing throughout the day. So for example, you have a runner, she might eat 2,000 kilocalories per day. She might go for a run and burn 600 kilocalories per day. If you do a DEXA or you have another way to measure her fat-free mass, she could potentially have 51 kilograms in fat-free mass. And so just doing that equation, that would get her to 27.5 kilocalories per kg of fat-free mass per day. And exercise energy expenditure is really anything that's what she's doing in terms of her athletic activity. So it used to be that we thought 30 was the magic number, and we still like to talk about this number a lot, but this is based on studies that were done by Ann Laux early on into the 1990s and reported into the early 2000s. And what she studied was habitually inactive, resting, sedentary women, and then put them through these very, very well-controlled studies over a course of a few days and found hormonal changes with that 30 kilocal per kg fat-free mass cutoff. But as we've tried to implement this in the real world, we see that not everybody has that perfect cutoff. Men can tolerate a lower energy availability. Optimal performance might be closer to 45 for some people. And certainly during adolescence, there's a higher need for energy because of growth and other things that are happening. So 30 is just kind of a place to start. So most people at this point have heard about female athlete triad, and this is a term that was coined to describe this interrelationship between low energy availability, menstrual dysfunction, and poor bone health. And so we used to focus on this really, really severe area in terms of low EA, functional hypothalamic amenorrhea, meaning the hypothalamic pituitary ovarian axis was shut down, and then full-on osteoporosis. But we realize these are related, and they all sort of they live on a different continuum, and they can be from the high end, where people could have really good energy intake, great bone building, and great bone density, all the way down to the low end. More recently, in 2014, there was an update by the International Olympic Committee to say, yes, the triad is absolutely a real thing. There's a lot of data about the triad, but we know when somebody has low energy availability that there are other health and performance consequences. We also know that low energy availability can happen to men as well. And so now we're starting to talk about the female and male athlete triad when we talk about this subset. And really that's more about reproductive hormone suppression. So it's not just amenorrhea for women, but it can be low testosterone and low libido for men. And they're very similar patterns in terms of low energy availability, leading to this hormonal downregulation and then poor bone health. So just some examples of this. In those studies by Laux, in these habitually sedentary women, as energy dropped, the energy availability dropped below 30 kilocalories per kg of fat-free mass per day, bone protein synthesis and mineralization dropped, insulin, which enhances amino acid uptake, dropped, IGF-1 dropped, which is a form of growth hormone that is produced at the liver, and T3 dropped. And all of those things are very important for bone. In another study, or in a subset of this study, what they found was bone formation, and this was measured by the hormones osteocalcin and P1NP. So those bone formation markers were suppressed at all levels of low energy availability. So 30, 20, and 10 kilocalories per kg of fat-free mass per day. Bone resorption, which was measured by NTX, was increased with the lowest energy availability condition. So initially it was just the bone formation that suppressed, but when energy availability was low enough, bone resorption actually increased. So then you had this decrease in bone formation and this big increase in resorption markers. More recently, also, it was interesting that these effects occurred within 5 days of the onset of energy deficiency. And this was without a reduction in estrogen yet. So lots of different hormones at play, and it's not just estrogen that's making this difference. More recently, Papageorgiou in the UK did some great studies looking at 5 days of low energy availability. And so this was really low energy availability using 15 kilocalories per kg of fat-free mass per day. And she did these studies in physically active men and women and found there was an increase in bone resorption and reduced bone formation in the women, but not in the men. And so here again, we're seeing proof that kilocalories per kg of fat-free mass per day, that energy availability may need to be lower in our male athletes to see the patterns that we see in the women. So this is a really busy slide. You don't need to memorize it. But the idea is a lot of the things that we're studying as a group internationally is looking at all of these different hormones' effects. And what exactly is the pattern that's coming into play? Is it all linear? Well, it's not really linear. We know that there are a lot of interrelationships between these different hormones. And low energy availability, like I said, isn't just suppressing estrogen. It's having effects on so many different hormones. And so some of the understanding we have here is based on what we know about the case of anorexia nervosa. So that's a situation where you have low energy availability, a decrease in energy balance. You have these appetite regulating hormones that are affected. You might have a decrease in body weight with restriction. And so this is going to lead to mechanical unloading. You have a decrease in leptin, which comes from fat cells because there's a decrease in fat tissue. And so then all of these things are starting to come into play with the pituitary, with the adrenal glands. And so all of these different FSH, LH, cortisol, estrogen, and testosterone patterns are feeding back to one another. As I mentioned, there's this downregulation with IGF-1, and that's actually growth hormone actually increases, but now there's a resistance to growth hormone at the liver where IGF-1 is produced. So how does this play into bone? Well, just like that other busy slide, we know that those hormones are very important for how bone regulates itself. So you can see some of the same words on the slide. Leptin, amylin, estrogen are all downregulated in low energy availability. And so those are all going to have an effect on pre-osteoclast, the hematopoietic stem cell going from a hematopoietic stem cell to a pre-osteoclast. And then these are going to have an effect as well on what's happening at the bone. In terms of the mesenchymal stem cells and the pre-osteoblasts, all of these things, decrease in leptin, decrease in T3, increase in cortisol, are going to have a negative effect there. So this is why these hormones are all having an interplay, and why this is so important to think about energy availability, having a direct effect on bone and then increasing stress reactions. So this was a study we did a few years ago, just talking about some of the similarities with women and men. And you can see that in both women and men, estradiol decreases. And we know that in men, estrogen is also important for bone. Testosterone in general, the studies have shown a decrease in testosterone in women and in men. Where you see this increase, sometimes they didn't control for PCOS. And if the energy availability wasn't low enough, sometimes the testosterone just wasn't shown to decrease. When we look at energy homeostasis, resting metabolic rate, leptin, both of those decrease in men and women. The appetite regulating hormones have the same patterns in women and men. And then T3 has been a great marker that we can use for energy restricted states. So I might have a female athlete who hasn't lost her menstrual cycle yet, but she's restricting very rapidly. And so in that early stage, I might see a decrease in T3. Then even when she's in a prolonged state, men and women, if they're in a prolonged state of low energy availability, will have low T3. So that's a nice marker for us to use. Growth hormone goes up because of the growth hormone resistance, and then IGF-1, like I said, goes down. So I won't get into all the different studies. You see a lot of Ackerman and 1040 on there, and a lot of others of us have been working on these projects trying to look at the relationship between different risk factors and in bone stress injury and REDS in bone stress injury. And so we know in general that athletes with low energy availability or REDS have a higher risk of bone stress injury. It's about a 1.7 to 4.5 fold increase. They have low bone mineral density. They have poor bone microarchitecture when we look at 3D images of bone, and they have decreased estimates of bone strength. This has been shown in models of functional hypothalamic amenorrhea, so women athletes who don't get their menstrual cycle. We see it in males who have low testosterone, so male endurance athletes, for example. We've seen correlations when we studied it looking at using screening tools or markers that are sort of secondary surrogate markers for low energy availability. And then even in other clinical surrogates, so really low BMI, low percent fat Z-score. For example, in a study of adolescent and young adult female athletes, high-risk bone stress injuries, so those risk injuries such as BSI, such as the femoral neck, were associated with both questionnaire surrogates of low energy availability and a BMD Z-score less than -1. Athletes with all three triad risk factors, so that low energy availability, menstrual or reproductive dysfunction, and low bone mineral density, were 2.5 times more likely to have a high-risk BSI than those with zero risk factors. And this is consistent with the increased prevalence of BMD with higher triad risk score, or sorry, should have said prevalence of low BMD with higher triad risk score in female and male athletes when they've done a modified scoring for those male athletes. So when we see our patients, whether they are coming in with a stress injury or not, we should be asking all sorts of questions. And this is where, you only have so much time in your visit. But if you are seeing somebody with a stress injury, make sure you get a good review of systems. Make sure you ask about other REDS risk factors, medical history. So what kind of fracture history have they had? Have they had repetitive bone stress injuries? Have they had good healing from a bone stress injury before they went back to running? We know that actually bone microarchitecture decreases for 12 weeks from the start of a bone stress injury until 12 weeks out, the bone microarchitecture gets worse and gets to a nadir. And then it takes another 12 weeks for that bone microarchitecture to get back to where it started. So we're returning our runners often very quickly. And that's why we sometimes see this pattern of repeat bone stress injuries. But when we talk about the medical history, we also want to get their growth history. Have they plateaued at all? Have they gone through a growth spurt? Are they on medications that may suppress their hormones? Are they on a birth control pill? Is that the reason they don't get their period? Or are they masking not getting their period and they're in a low energy availability state? Are they taking a medicine that is detrimental to bones? So do they have, for example, asthma and they're taking steroids a lot? You want to ask a pubertal and menstrual history. And we do need to ask our male athletes about libido. This can be uncomfortable for some people and in some countries, but it is a marker. Low libido and a decrease in morning erections is a marker for low energy availability. We want to ask about their training history, if they've ramped up quickly, of course, their dietary history, if they've had any major restrictions, and then family history of fractures, osteoporosis, delayed puberty, and endocrine disorders. So in the medical profession, we can often spot RED-S. We're getting much more attuned to it, but we need to very often prove it to the athlete. And so there are various signs and symptoms. We can talk about the fact that their performance has decreased. We can talk about the fact that they have cold intolerance. We can talk about the fact that they have worse vascular flow to their extremities. Sometimes we can help them see the signs. Like in this DEXA, I can show them this person has very little fat. They have barely any yellow on their DEXA scan when we can do body comp. In a female athlete, it might be low FSH, LH estradiol. It could be decreased libido in men and in women. It can be low testosterone in men, a low white blood cell count, low iron or ferritin, that low T3, low vitamin D, increased liver function tests, so AST and ALT, altered lipid panels, decreased performance, decreased bone mineral density, low BMI, low fat mass. And then the treatment is about improving the energy availability. So it's not about putting people on the oral contraceptive pill. It's about getting their menstrual cycles back. Sometimes there is a role for transdermal estrogen, which can help increase bone density because it's metabolized differently than taking estrogen orally. But overall, the main treatment is improved nutrition, improving training, and improving mental health. So just a little teaser, in the next few months, you will see that the IOC group has a RED-S clinical assessment tool coming out. And so there are going to be these primary indicators and secondary indicators that talk about giving people a training zone. So we know that the triad return to play criteria was developed many years ago that was very, very helpful. And it talked about basically menstrual history, eating disorder history, bone mineral density, fracture history. The RED-S CAT is going to be doing that, but adding a lot of other factors that we can put into play so that we can put our athletes into these categories about treatment and also return to play. Other good resources about this topic, I can share my slides later, but the BJSM has had some great articles about this, both with Triad and with RED-S. We have an article in Up to Date about functional hypothalamic amenorrhea, and there's more about the Endocrine Society clinical practice guidelines for female athletes with amenorrhea that can often be helpful to follow those guidelines when you're treating somebody with amenorrhea and a bone stress injury. And then finally, we launched this website. This is an international group of people. The more the merrier. If anybody has any resources they want to put on that site, we just keep that up to date as much as we can to give people some more information and resources about relative energy deficiency in sport. And then stay tuned for that British Journal edition that's coming out. And our Female Athlete Conference is coming this summer, where we'll be talking about a lot of these issues, and it launches today. So thanks. I'm happy to take questions now or after everyone else.
Thank you very much. Congratulations, Catherine. Very spectacular speech. Very interesting references and very nice information. If you can, please stay with us, and we will do the question and answers at the end of the 3 talks.
Sounds good.
And so we will give time to the audience to think about. I will say now what I said already on the chat. If you have any question, use the chat, type your questions on the chat, and we will raise your questions to the speakers. So thank you. Very interesting. We are very much looking forward to the publication of the RED-S update. So hopefully it's coming perhaps in April or something like that. We don't hear you.
It'll probably be later than that since there's so many supported papers, but it will be in 2023.
We'll like this. Looking for it. And
yeah, just anyway, look
for it. We will very much anticipate it. Good. Now it's Tony turn. Tony is a lovely girl, that neighbor of my wife and myself, that is a very active, keen triathlete, and she can maybe later and during the question and answers share with us her own experience with bone stress injuries. Anyway, she has 12 years of experience with elite and professional athletes in Aspetar and at her home country, South Africa. Much of her focus has been with youth athletes, so she spends a lot of time with the young people with adolescent injuries. She is a social endurance athlete, as I said, and well, she has experienced all the burden of the psychological and the physical burden of injuries, so we can discuss with her later during the question and answers. Tony, yeah, the floor is yours. Thank you.
Thanks, Juan Manuel. Hi to everyone. Thanks so much for joining us this afternoon as we explore the very relevant topic of bone stress injuries. As Juan Manuel says, I'm Tony Snoxel, a physio currently working in the male athlete department. And bone stress injury is a topic close to my heart, as I have been the unfortunate victim to more than a few occurrences, and I work with a number of young athletes struggling with this multidimensional injury. I have no conflict of interest in relation to this presentation today. So, what is our plan? This evening, I'll discuss the role of physiotherapy in rehabilitation of bone stress injuries in quite a practical and informal way. I'll address when to adopt a more conservative approach to management, go into some detail about what to note during the subjective examination. I'll discuss which capacities we measure, as any deficits may have predisposed them to injury. Next, I'll cover how we create a multifaceted rehabilitation program, which covers all aspects of development. I'll address the timelines that I follow for important milestones, as well as how to progress or regress rehabilitation. And lastly, I hope to provide some tips to prevent re-injury. So what can we as rehabilitation specialists do to help patients with bone stress injuries? It's probably more accurate to ask, what can we not do? And as Catherine actually said, we cannot speed up an athlete's recovery, but we certainly can slow it down with poor assessment and journey planning. You'll get sick of hearing me say this, because I say it throughout this presentation, but education is essential from day one post-injury. The athletes, our patients, must understand the severity and the risk of delayed healing and potential reoccurrence if an adequate amount of time is not taken to ensure good healing and progression. We aim to provide the best internal and external environment for healing, one where the surrounding muscles are strong and flexible, joints are stable but mobile, and the athlete maintains a good level of general fitness and conditioning. Wolff's Law says that controlled progressive loading, as well as strength, motor control, proprioception, and biomechanical development, can have a positive effect on the stimulation of osteoblastic activity. And this is essentially what we're aiming to achieve. So different bony structures present with higher or lower risks of prolonged healing and reoccurrence. High-risk areas include the lumbar spine, specifically a spondylolysis, the femoral neck, the patella, tibial plateau, the anterior tibia, the medial malleolus, the second and fifth metatarsal base, the talus, and the navicular. So these regions require a more conservative approach. Patients with a generally low level of conditioning, whether it be fitness, strength, or other capacity deficits detected on assessment, are prone to developing other overuse injuries if rehabilitation is too aggressive. The low risk areas, or if we're dealing with a high level athlete, less focus can be on time and more on symptom progression and associated outcomes like strength and motor control. So the subjective assessment is, in my opinion, the most important step in returning an athlete to their sport quickly and safely. Communication is key, so having a translator could be useful, especially within our population. Often the athletes that we see are minors, so we insist an adult accompanies them, both from a legal aspect, but also as children are often poor historians and parents could provide more accurate information, particularly regarding timeframes. We want to know where the pain is, and while we have this information from SMP notes and radiology, we still want to hear it from the patient and find out if there's any associated areas of pain. So while the most obvious symptom is usually pain, we need patients to qualify it in terms of severity, irritability, nature, whether it's local or diffuse, sharp or dull, and make sure that there's no other associated symptoms. So radiating pain in the case of a spondylolysis, for example, could raise some alarm bells. We need to know when the pain started, whether it had a quick or gradual onset, whether there was a trauma associated, and how much time passed between symptom onset and cessation of activity. The injuries are usually load related, so we want to identify the load that the athlete was exposed to at the time of injury compared to the preceding loads. So this is that acute to chronic workload that we so often talk about. We want to know the load of the training duration, the distance they covered, the frequency of training, the intensity of sessions, and what surface they ran on. Also, hearing about any recent competitions that they've taken part in is important. Competitions or important matches in the case of field sports and team sport athletes, because we can assume that there was likely a ramp up in training leading up to that competition. Having a detailed timeline about symptom onset, days since the last training or competition, and time since imaging just helps to create a realistic prognosis and plan for the athlete. So this list of subjective questioning is not exhaustive, but it covers some of the most important areas that we ask. So as mentioned again, past history of bone stress injuries and other MSK injuries can be a risk factor for this current presentation. Certain medications, particularly corticosteroids, can be a factor. Ethnicity plays a role. We're not sure how large that role is, but there are lower rates of bone stress injuries in the African American populations compared to Caucasian and Asian groups. In the Middle East particularly, vitamin D deficits are so prevalent, and we know that this really does prolong tissue healing. It's sometimes difficult to pick up on nutritional red flags in the first session with an athlete, but as we build a relationship with them, often they'll open up about these and other associated psychological aspects surrounding their performance. I'll often ask about diet in the first session and be told that it's great, only to realize 3 weeks down the line that they're living on chips and Mountain Dew. Menstrual irregularities could indicate RDS and overtraining, and poor sleep and general recovery strategies put the athletes at risk of prolonged rehabilitation and associated injuries, of course. Often the athletes that we see have already had some form of treatment within their club before coming to us. So we always want to know exactly what was done, what helped, what didn't help, and just in general, what kind of training and rehabilitation they've been exposed to. And lastly, we need to know the specificity about the sport and the position requirements and the level of performance that the athlete aims to return to be able to effectively plan our management. Finding out about any upcoming competition is also important just to kind of manage expectations. If someone's coming in with a grade 3 spondy, chances are they're not going to compete in the volleyball match that's happening in 6 weeks' time. And we need to be upfront about that. Okay, so the objective assessment is our next step. This is where we start to pick out physical risk factors that could have predisposed them to injury. Viewing the imaging is useful for grading bone stress injuries, but more importantly, we want to see how these findings relate to the clinical ones. We know that the changes seen on imaging can still be present up to a year after initial injury, so clinical correlation is necessary. We look and feel for areas of swelling, and while this is rare, it can occur in some severe cases. We assess the patient's weight-bearing status, and if an athlete is walking without any aids but has intelligent gait or a weight shift in standing, then it's best to refer them to OPD for crutches or bracing. I always ask to see their training shoes, and this often means that they need to bring them into a follow-up session. I look at areas of excessive wear and different loading changes, and particularly in the case of track and field athletes, we need to find out how much mileage has been covered in the shoes, as unfortunately, the new Rage with the carbon-plated shoes seem to have a very short lifespan, despite the incredible prices. I also like to encourage my athletes to keep a log of the mileage that they cover in each pair of shoes and to rotate the shoes wherever possible. We conduct a quick movement and posture analysis, looking for obvious abnormalities like varus valgus knees, pes planus, just to mention two. Provided patients are full weight bearing, I always want to check a double leg and single leg squat, a lunge, and a heel raise. This gives an idea not only about strength, but also about how much exposure they've had to strength training, as many of these adolescents have never stepped foot in a gym. Specific strength and flexibility measurements are dependent on the athlete and the sporting demands, and these are decisions we make when they come for their assessment. So after gathering all the information we can, the next step is to plan our treatment strategy. So athletes want to know when they can achieve the most important milestones: running, jumping, shooting, returning to full play. This time frame depends on not only the grade, region, and level of risk of injury, but also the clinical picture, as I keep mentioning, that the patient presents with. We need to educate about the risk factors associated with their bone stress injury, whether it be poor footwear or diet, lack of vitamin D, or a sudden increase in their training load, and then make the necessary referrals to subunits. We discuss what we've seen and what it all means, and then turn the question around to the patient, asking them what they have understood to ensure optimal buy-in. It's frightening how often I think that I've explained everything in the most simplistic terms, only to realize the young athlete hasn't understood me at all. So not all patients require walking support or weight-bearing limitations, but those that do will always want to know upfront how long they're going to be needed. Low and high risk bone stress injuries of the foot can generally weight bear fully in 4 to 6 weeks. Tibial shaft and medial malleolus injuries could require a longer period of 6 to 8 weeks. Bone stress injuries of the femoral neck and shaft can have weight-bearing limitations up to 8 weeks, while despite being low risk, the ramus and sacrum may require support for up to 12 weeks. All this is highly variable, however, and again, it depends on the symptoms that the patient presents with. Tables like this are quite a nice guideline to at least give the patient up front to manage their expectations and just to guide your treatment. Running progression starts when the patient is pain-free during and after all ADLs as well as rehabilitation sessions. Additionally, I start with early plyometrics and landing drills, double leg progressing to single leg. Once these are pain-free and they can be performed with good mechanics, I consider it safe to start a running program. The details of progression are dependent on age, level, and specific sport of the athlete in front of us. Throughout the first level, patients will do run-walk sessions with increasing run time and decreasing walk time. During the second level, the aim is to increase running pace as higher velocities result in increased ground forces and therefore bony impact. Runs will start very slow, 60% of their normal pace, and increase to 100%. Once a patient is able to run for 30 minutes at their pre-injury speed, then they enter the final stage of the program where they'll increase their speed to max pace. This is where sport specificity becomes very important. A football player does not need to run at their max pace for 30 minutes. They'll benefit from more short, repeated running drills at very high velocities. Track and field or long-distance athletes would follow a program similar to this. We always skip a day between running sessions to monitor the development of symptoms and to ensure gradual loading. Athletes move to the next stage of the program if they're asymptomatic during and the day after a session. If they develop symptoms, we simply regress to the level before, sometimes staying at that stage for a few sessions before progressing again. When this happens, I often find athletes get a bit stressed about their progression and the fact that we have to regress. And it's when I just remind them that no injury follows a perfect upward curve. There are going to be days where they're going to feel great and days where they're going to have a flare-up because their body just wasn't able to stand the load for that day, and that's perfectly normal. When they have that pain, it doesn't mean they've really injured themselves. The body's really good at giving a nice warning sign, and as long as we listen to it, they can progress in the next day or two. The physiotherapy sessions involve a mix of pain relieving and rehabilitation tools, depending on what we found in assessment. Soft tissue techniques, ice or the bone stimulator, may be helpful in early stages. The bone stimulator makes use of low-dose ultrasound on the injury site. And while it is time-consuming, it's proven to be quite effective. And if I do use it, I generally will get my whole session done, and then the last 20 minutes they can sit with that and sit on their phone. Low impact cardiovascular training is essential throughout rehabilitation, and athletes who are over the age of 16 are referred to our fitness coaches. Younger athletes or those not registered or not able to attend fitness are educated about the need to maintain those levels. Strength training, motor control, and proprioception training forms the bulk of sessions with us. We need to address deficits early and ensure that the athlete we return to the field is robust and at a lower risk of re-injury than they were before stepping into our clinic. Sports skills are introduced when patients are asymptomatic and have adequate strength and motor control to perform them safely. Once again, education about the importance of adhering to rehabilitation guidelines is reinforced daily. If patients have access to a swimming pool, they're encouraged to swim to maintain cardiovascular fitness. Hydrotherapy sessions can be beneficial in more high-risk and high-grade cases. The Hydro team provides 3 to 4 sessions over 2 weeks, which is specifically run progression. So I'd only really refer them when they're nearing the stage when they could start a land running program. In week 1, they run a 20% body weight at 6 to 7 kilometers per hour, and in week 2 at 30 to 40% body weight, also at 7 to 8 kilometers per hour. So this really is a gentle introduction and could be considered to have more of a psychological benefit. This means that they just get to enjoy the sensation of running again, which is often what these athletes are missing. After completing hydrotherapy, we may decide to start with an Alter-G running program, which begins at 50% body weight to bridge the gap between water and full weight bearing running. Personally, I'm a big advocate of the aqua jogger. It's an incredibly boring task, but if you can endure that, there's no better way to maintain running fitness and to just keep that feeling of running throughout your healing time. So rehabilitation progression depends on the whole clinical picture and whether certain outcomes are achieved. Once they're full weight bearing, pain-free with gait, rehab, and ADLs, and have near equal strength to opposite side, then they're considered ready for early plyometrics. Double leg jumps and landing are progressed to single leg. If these are pain-free and performed with good motor control and adequate explosiveness, then they can initiate the running program that I detailed before. We then include high-speed running, acceleration of deceleration, change of direction, and sports skills. Athletes older than 16 competing in team sports are referred to the assessment unit, after which they begin specific team sessions. Once these have been completed, they're considered appropriate for discharge. The track and field and endurance athletes are given progressions to go through on their own or with their training group while still attending physio until they have returned to the same level of training as they were prior to the injury. Certain sports and coaching methods predispose athletes to suffering re-injury. The risk can be reduced by education about training load, particularly after periods of rest. They are reminded to avoid sudden increases or changes in their training load intensity, surface, inclination, or footwear. Maintaining overall muscle strength and motor control can further reduce the likelihood of not only another bone stress injury, but any musculoskeletal injury. We educate about effective recovery strategies, particularly good sleep and nutrition, as well as stress management. As athletes mature, it's important to listen to the warning signs that their bodies are giving them to avoid further injury. Wherever possible, I like to communicate with the coaching and medical team involved at the club that they are training at to ensure all the work that we've done isn't a waste and that some mistakes are not repeated. It also ensures that when they do return, they do so at a gradual pace and they don't enter the first session at 100%. In summary, these are some of the take-home messages. Careful, detailed subjective assessment is key. Assessment of capacity deficits, whether they be strength, motor control, or other, helps to plan our management. Rehabilitation must be broad and help to develop the athlete as a whole. Careful progression or regression of rehabilitation is always based on symptom presentation and the clinical picture. High-risk injury regions need more conservative management, and being impatient and progressing too quickly does more harm than good. Load increases when the athlete returns to training must be gradual. They need to be educated about load management, particularly after periods of rest to avoid re-injury. Thank you so much for listening to me waffle on for about 20 minutes. I look forward to answering your questions at the end of our presentation.
Brilliant presentation, Tony. Thank you very much. Congrats. So we will ask the audience to start to raise questions on the chat. We will discuss with you later on. Okay, we have our next speaker ready. Well, thank you very much for joining us. Adam Tinfordi is kind of one rising star in sports medicine, publishing like hell. I don't know how do you do it.
Effective collaborations, and
I know. He just published yesterday for you to know. We can share later. 2 days ago, he published in the Sports Medicine Journal a very interesting paper about bone stress injury. We can discuss this later. And now, 2 weeks ago in bone stress in sports medicine, in British Journal of Sport Medicine. So amazing. Good. Let me introduce you to the audience. Adam Tinfordi is associate professor in the Department of Physical Medicine and Rehabilitation in the Harvard Medical School. Another distinguished invitee from Boston. Thank you. He serves as the director of both running medicine and shockwave medicine at Spaulding Rehabilitation Hospital in Boston. He has published about 140 papers focusing in bone stress injuries, overuse injuries on runners, shockwave therapy, etc. And he will talk to us now about the shockwave therapy and orthobiologics in the management of bone stress injury. Thank you, Adam, for joining us. Thank you.
All right, we'll proceed. So these are my disclosures, none of which are relevant for the purposes of this talk. So first, I'm going to describe the mechanisms for how shockwave and other orthobiologic procedures may be helpful for tissue remodeling, particularly in the management of bone stress injuries. I'm then going to describe the best application of shockwave for clinical practice and understand what is our current evidence for use of treatment. I think the really important takeaways are from the first two speakers of doing a good job with risk stratification, identifying the multiple complex risk factors that oftentimes contribute to these injuries, and then identifying key movement impairments and providing the appropriate education to return to pain-free level of sport. Shockwave really represents, and in these orthobiologic procedures, an opportunity for us to do something more, particularly in high-level athletes or athletes with injuries that have not healed with a more conservative treatment. So we published on shockwave. This is an open access article from 2018. And when I started shockwave over 5 years ago, I wanted to make sure that everything I was doing was evidence-based and was applying the science the most effectively. Really, what we've learned from reviewing the literature on shockwave is this represents an external form of energy. There are differences in how shockwave applied to tissues at different energy settings will affect tissue healing. So it's really important if you're looking at using something like shockwave, given the limited level of studies that have been performed in this topic, to understand the biological plausibility of certain equipment and the appropriate dosing. Because each of these different forms of shockwave energy and types of shockwave will have different effects on the target tissue. So this cartoon illustrates what shockwave looks like. There is a positive energy phase followed by a negative energy phase. True shockwave has a very high amplitude positive energy phase, as illustrated by the dark line. The radial pressure wave is more of a sinusoidal appearance of a positive and negative phase of energy. And so when we're describing shockwave for management of a bone injury, we really need to be utilizing true shockwave, which is usually generated using the focused devices. These are a schematic of the different forms of shockwave that are available. There are forms that are electrohydraulic, electromagnetic, or piezoelectric. And those three devices are typically under the class of focused shockwave device, able to generate high energy shockwaves that would be appropriate for treatment of bone stress injury. In the lower panel, D represents radial pressure wave, where a ballistic strikes an applicator head, generating pressure waves, which will interact with the tissue. However, the challenge with using the pressure wave device is that the energy settings typically don't meet the threshold for high energy shockwave. And the way that the radial pressure waves are generated, it tends to create quite a bit of vibrational energy. When we go back to some of the understood involvement of bone, when the periosteum is acutely inflamed, the application of repetitive vibratory stimuli is going to be quite painful. So I'm typically thinking about the use of focused shockwave at the correct energy settings if I'm going to treat an athlete with this injury. Now, these devices have also really transformed in the clinic space. On the left is illustration of the early shockwave devices. And, you know, honestly, if someone showed me that image, I would be very hesitant to sign up. On the right illustrates what my device setup looks like in clinic. It's a portable device. It's on a treatment table. It's the size of a 1990s desktop computer. And so it can be used effectively in clinic without needing to have time in a CT suite and without prolonged time and planning to deliver the treatment. So there are two mechanisms of action that have been proposed for shockwave. One is in disrupting the inflammatory cascade to facilitate tissue remodeling. And the second is on pain modulation. So again, our goal in treating the injured athlete with bone stress injury is to achieve a pain-free status and then gradual return in load while correcting impairments biologically and biomechanically with full return to sport and ensuring that the athlete is completely pain-free. So sometimes we're treating concomitant tendinopathy with bone stress injury. So ensuring that we have achieved targeting all of these tissues can sometimes more reliably allow a return to sport in a pain-free status. So the energy level for bone healing, as I mentioned in earlier slides, really needs to be using focused shockwave. This high energy focused shockwave is postulated to result in a release of nitrous oxide, upregulating neurotransmitters, and release of vascular epithelial growth factor, which then helps to revascularize the bone. Now, there is also some emerging work in extracorporeal magnetic transduction therapy, otherwise referred to as EMTT. I'm starting to utilize this in my clinic, but there's a lot of excitement about this device, as we would refer to as a team player with focused shockwave, where it generates this very high frequency electromagnetic pulse sequence, which may help then with cellular membrane permeability and cell signaling to help to stimulate bone healing. It can be quite helpful for management of delayed union, non-union, and bone stress injury based on some preliminary work that needs to be further substantiated into larger clinical practice and trials within stress fracture. But you may start to hear about EMTT, recognizing that is on the spectrum of different development in targeted interventions for bone. So the advantages of shockwave is, first, it's non-invasive. These devices sit outside of the body, therefore they are extracorporeal. They have a favorable side effect profile. In all randomized controlled trials, there are 2 women who ruptured their Achilles tendon at over age 60 using a high energy focused device within 2 weeks of treatment. And there I've described the 2 major side effects that have been reported across all randomized controlled studies. So that's an extremely uncommon event, but something that you have to think about when you're dosing the energy for tendon. We do not see evidence of complications in the management of bone injury with shockwave. And the nice part about this, as I mentioned earlier, is that we're able to treat both the bone and the non-bone impairments in the athlete, with the goal then that we can have a more successful return to pain-free status and return to sport. So what is the level of evidence? Well, we're really looking at level 4 evidence based on the current research that is available. And I'll present some of my work looking at runners that I've been treating. But when patients ask me, what is the level of evidence? I cite these two studies. The first is by Taki in 2007. This was 5 athletes with non-union stress fracture, so 1 year, 2 with treatment of tibial stress fracture, 1 with a 5th metatarsal stress fracture, 1 with an inferior pubic ramus, and 1 with a medial malleolus of the ankle injury. They all received 1 session of focused shockwave using the Oscitron, which was that earlier illustration, a very larger device, which oftentimes would use CT guidance and is quite painful. So in the early application of shockwave, anesthetic was typically offered. And then all of those individuals that received 1 session of shockwave were able to achieve bony consolidation on repeat radiographs and return to sport, 4 months following 1 treatment. So again, 4 months return to sport for a bone stress injury would not be unheard of, but for injuries that were classified as non-union, it's quite promising. There was a second investigation by Moretti. This was in 10 athletes with either a Jones fracture, which again is that injury at the metaphyseal diaphyseal junction, an area of relative avascularity and high risk of complications of non-union or recurrence with return to sport, or athletes with anterior tibial diaphysis fracture, as illustrated before by Dr. Ackerman with those dreaded black lines. Each received 3 to 4 sessions of focused shockwave every 48 to 72 hours. All of these athletes achieved bone fusion within 6 to 14 weeks and a return to sport in a range of 3 to 10 months. Most returned at 3 to 4 months. And what was remarkable about this study was a few of these athletes had failed to achieve bony consolidation with ORIF. So these individuals were having the focused shockwave applied as essentially a salvage procedure. And what was exciting was all these athletes were able to return to their sport. So what are my observations in treating, again, a grade 4 bone stress injury, otherwise referred to as a stress fracture in runners? I'm looking right now at all of the outcomes in my patients. I oftentimes get referrals from Dr. Ackerman and others for very frustrated athletes that have really done everything to optimize the biological and biomechanical factors contributing to their injury. We've looked at starting with our grade 4 bone stress injury, otherwise referred to as stress fracture. We identified 15 runners, including 7 with delayed union or non-union. All of these athletes elected to proceed with shockwave in my clinic. This was 3 to 4 weekly sessions with delivery of focused shockwave of 3,000 to 4,000 shocks, with a minimum threshold of 0.30 millijoules of energy, which is defined as high energy shockwave. But oftentimes I would titrate them up to maxing out the machine. It's quite painful, has to be done slowly, but athletes are very tough and are very motivated to return to sport. All these individuals would be reevaluated 6 weeks after their initial series of treatment, with the goal then to advance their rehabilitation program and determine return to sport. Additionally, I will apply shockwave as an anabolic stimuli in the return to sport, because as Dr. Ackerman showed in the study I collaborated on, we know that bone can be at its weakest point at 12 weeks and may take 6 months to reach its full strength. So continuing to keep the bone in a net anabolic response, the goal is to prevent this from falling back into a state of disrepair. What did we observe in these 15 runners? Well, 14 of 15 were able to achieve pain-free status and subsequently return to running. We had one athlete that had a delayed presentation of a navicular stress fracture, who we did shockwave. We even introduced orthobiologic procedure. Unfortunately, this athlete went on to have surgery because she had failure to see bony consolidation on serial CT images. Again, a challenging injury to treat at baseline, but of those that we treated, 14 to 15 were able to return to sport. We looked at them using, triad and RED-S stratification, and even individuals in the moderate and high risk category were achieving treatment success with shockwave. We also think about the use of orthobiologics. These are cell-based treatments of blood, fat, or bone. These are oftentimes best described in the intraoperative management, where individuals will get bone grafting. I was the co-senior author on this paper with Honig, with Dr. Ackerman and others, where we were asked to actually expand on the topic of orthobiologics, for which we replied that there, is still work to be done in this topic to understand the relative role in a treatment. So we're really starting to explore, though, how we might utilize this in our athletes. I'll just share a couple of cases, though, that I've been involved in. This was a case report that I collaborated on for an individual with non-union of a cuboid fracture. This was seen in a runner who had plantar fasciitis and subsequently developed cuboid stress fracture. That biomechanical association has been reported in a few athletes. Had CT findings of fracture with failure to see improvement with immobilization. Subsequently received a single injection of autologous bone marrow aspirate harvested from the iliac crest. You can see on the right in panel A, a short axis view of the needle coming into plane into the bony cleft. 10-week follow-up CT demonstrated resolution of the prior fracture that was visualized. This is another interesting case that I had in clinic of an American-style football player who had a high ankle injury, ultimately requiring surgery. Subsequently returned to sport and developed a medial malleolar stress fracture. Now, this individual came to me for an additional opinion. I was not a second opinion. I was an additional opinion. And he had serial CTs which showed a lack of bony consolidation. You can see those weeks 0, the original fracture line. Week 4, you can almost see a walling off. That fracture looks much more visible. And on week 11, that fracture line is quite visible. That individual elected to proceed with shockwave with me. I did 3 sessions followed by the autologous bone marrow aspirate injection on week 14. At week 19, we see a nice filling in of the defect. We did additional shockwave treatment. And at week 24, you see a good bony bridging. There is still the presence of some endosteal changes, but this athlete essentially was able to return back to full sports participation without return of pain. We also have looked at shockwave in combination with gait retraining. This was when I only had the use of radial pressure wave, had a very frustrated athlete with 7-year history of anterior leg pain, initially read as a low-grade tibial bone stress injury, managed appropriately, but every time she returned to sport, she had a return of pain. She was seen for gait evaluation and retraining, but on return to running, had immediate return of pain. On X-ray, had some just generalized thickening of the anterior tibia. So without the presence of bone stress changes. So what I ended up doing was 3 sessions of radial pressure wave which, as I described before, is very uncomfortable, but this was the only tool I had at my disposal prior to acquiring Focus Shockwave in my clinic. She was able to, after the first couple of days of having trouble walking, a few days subsequently went for her first run that was pain-free in 7 years and was able to go through gait retraining. We looked at this over the course of her gait retraining protocol. You can see that she was followed for a good amount of time, but ultimately she provided this just very enthusiastic statement. We won't take the time to read it together, but essentially just describing how despondent she was, how she had tried everything else and really was starting to give up on return to the sport of running. But through the use of the Shockwave and the gait retraining, really was able to get back into full sport, and her goal is to train for half marathon. And this was a few years follow-up, no return of pain. So we're still working to develop best practices. I'm developing some consensus guidelines on how we can think about this in sports medicine applications. But again, this is another open access article that I can reference that can give you a little bit more in terms of my thought process for the treatment of bone stress injury with Shockwave. You really should think about other factors though, and ensuring that this individual is appropriate for Shockwave. Again, I think they deserve the appropriate biological and biomechanical workup. You want to make sure that they're not on anti-inflammatories, as has been shown by Dr. Ackerman, Dr. Pop, Dr. Buckstein, and others, that the use of anti-inflammatories may be a predisposing risk factor for bone injury and certainly would disrupt the inflammatory milieu we're trying to accomplish with Shockwave. You need to be careful if an individual has open growth plates. We don't do Shockwave in individuals that are pregnant just because we want to make sure that the treatment is safe. We will not do it in areas of malignancy, and you have to take some care with localized infection. And this really needs to be done slowly, titrating up to clinical effect because it is quite painful. Our outcomes are oftentimes seen 12 weeks or longer after the last session. That's really from the tendinopathy literature for bone stress injury. What we will typically do is get a CT 6 weeks after the initial series of Shockwave is performed, ensure they have bony consolidation before advancing into multi-directional loading, hopping activities, and gradual return to run. And we'll continue to do Shockwave to maintain a net anabolic response. The role of an MRI is variable. I will think about this in the pelvic region where a CT would not be the most responsible thing to acquire due to the high amount of ionizing radiation. But you also need to recognize that Shockwave is an inflammasome, and an MRI might show a lot of non-specific edema as a result of Shockwave. So you need to be careful when you get an MRI to stage recovery from injury. So with that, I'll thank you for your time, and I think we're opening up now to discussion.
Thank you very much, Adam. Very nice presentation. I thank the three speakers for summarizing so much and broad information into a little bit more than 20 minutes each of you. So thank you for doing that effort. It's much appreciated. We have some questions in the audience on the chat. I still encourage any member of the audience to use the chat to raise your questions. Catherine has been so kind that already answered 2 of the questions that were raised. I have one question for Catherine, though. Maybe one of the questions is when to order blood work when we want to investigate a potential REDS, and what blood markers do you suggest we can order?
Yeah, that's a great question. So if we have a suspicion of REDS and we think somebody has low energy availability, then the things that I would start with off the bat would be a metabolic panel, a complete metabolic panel, a complete blood count. I would check a vitamin D, a 25-OH vitamin D. I would check PTH. In our complete metabolic panel, we have calcium, phosphorus, magnesium, so that's in there. And then if I want to find markers to really look for low energy availability, I'm looking for things like the liver enzymes. So AST, ALT, I'll look for low T3. So I do get a free or a total T3. If it's a female athlete and she's not getting menstrual cycles, then there's the whole hormonal workup to determine why that is. So we always have to remember there's a differential here when someone doesn't get a menstrual cycle. So FSH, LH, estradiol, we're thinking about the pituitary. So we're looking at prolactin. We're also thinking about if it's somebody who's fallen off the growth curve, looking at IGF-1. So it really depends on the full picture of RED-S. And then in our male athletes, we'll also check a testosterone, and those labs should be done in the morning at 8 a.m.
Good, good. So it's a very comprehensive work. That could be a little bit expensive. So how do you manage with the insurance aspect?
So it depends on how severe the issue is. You know, sometimes if I see somebody coming in and I don't think they're medically unstable, but I very much know what the issue is, I might not need to get the labs. You know, if I see somebody who's lost a bunch of weight and they have admitted that they have been restricting, I don't necessarily need the labs to prove that it's RED-S. And so if I can't afford to do the labs, then the first referral will be to a dietitian to help analyze the diet. And that doesn't need to have a very expensive, complicated metabolic test. It can just simply be reviewing the exercise, reviewing the intake. I think it depends where you're practicing to determine how in depth you need to go. But sometimes, like I said, we can recognize it and we just need to prove it to the patient. I often have labs, or I have patients whose mothers, for example, will say, oh, no, this can't be what's going on with my daughter. There's no way, you know, you have to do all this huge workup and spend a lot of money. And I remind them that, no, it absolutely can be as simple as it sounds. And it's just that we got to get going with the dietitian and let my colleague, the dietitian, start unpacking the nutrition part.
Good, good. Thank you. Tony, we have a question to you from our colleague in Aspetar, the psychologist Sofian. And he first thank you for mentioning the psychological aspect of RED-S. And he asks you potential red flags or warning signs to refer an athlete to psychologist.
Great. Thanks for the question, Sofian. I think in the rehab department, we're lucky enough to be able to spend up to an hour with our patients 3 times a week. I think a lot of other professions, they don't get that. You know, you're having that quick little chat and you can often not pick up those flags. So I do think from the physiotherapist side of things, we're often the first people that can see that. So it's usually worse with female athletes, but that's not to say that men don't struggle with the same sort of psychological issues. But things that I'll notice is the first thing one of the girls will say is they're worried about weight gain during their rehabilitation. They're used to training 80, 90 kilometers per week, and they'll be quite nervous and anxious about picking up weight. They might come to sessions feeling a little bit dizzy. After a few leg press, they report that they can't carry on. They don't have the energy for the session. That's something that I'll pick on, and I might find out then that, they skipped breakfast today. Very often they don't want to look in the mirror when I do feedback sessions. So I've noticed that, which is very sad. I want them to have a look at the control that they're needing to perform the activity, and they'll be uncomfortable looking in the mirror. That's another red flag. They might not want to visit the nutritionist. So as a standard with bone stress injuries, we will do a referral to the nutritionist, but our nutritionists will often then require that they take a protein shake after their physio sessions. And that'll be a red flag for me when I might do the referral. Maybe they go to the nutritionist, but they don't take their protein afterwards because they're so concerned about the extra weight that they're going to have. And then there was one other thing that I had a look at that. That was basically, those are the things that I'll have a look at. And you can only really get it by spending an hour a few times per week. But those are the things I notice.
By the way, Catherine also answered a little bit this on the chat, saying that these potential signs of referral group could be signs of depression, anxiety, resistant to treatment or poor progression, things like that, right? I have a question for you, Adam, actually two, together. So imagine you have a female athlete with a femur neck on the tension side, on the lateral side, will you use a wave therapy? It's a deep one. And so if you use it, what kind?
So you're asking, do I go after it with shockwave right off the bat? So I think first we have to ask the right questions. You know, we need to have a really detailed history exam. We need to, screen to make sure they don't have biological risk factors. Dr. Ackerman and I have seen that strong association with femneck bone stress injuries with low bone mass. So we're gonna actively pursue a biological workup. Now the question is, you're going to be on crutches and you're going to have to offload that probably 4 to 6 weeks. You're probably going to need some form of serial scan to ensure bony consolidation if you're truly dealing with a tension-sided injury. And in fairness, there is the question of whether you should at least have a discussion with the surgeon. And I think I would typically do that just to lay all the cards on the table, recognizing this may not heal with conservative treatment. But recognizing then that we're exploring all of those topics, you could do shockwave. Typically, I'll have that person go into kind of a frog leg position. The device I use is electrohydraulic shockwave. The lens is off. I'm directing it right at the femoral neck. It's very uncomfortable. You have to have a lot of trust with your athlete because that is just a very sensitive area to be treating in anyone, and to be maintaining prolonged contact with a shockwave device. It's making sure that everyone feels comfortable, that they've got the right comfort level with that process. And you could say, well, that's a crazy idea. Why would you apply shockwave to a femoral neck? Well, why are we concerned about a femoral neck stress fracture? We're concerned about non-union. We're concerned about avascular necrosis of the femoral head. What does the literature tell us about the use of shockwave for AVN in the femoral head? It actually shows that it can be just as effective as core decompression surgery.
Yep.
So if we're already concerned that this person might need surgery, a very provocative question is, do you apply shockwave as a prophylaxis to prevent AVN? Do you consider this as a perioperative, postoperative strategy? And there are some surgeons that I've learned a ton from on shockwave that are using this as a perioperative, postoperative management. So first, do no harm. I think it's reasonable to consider. Make sure that you're not just the guy or the gal holding the shockwave device, though, saying you're going to fix everything, because that's just factually inaccurate. And is doing a disservice to that athlete to not understand what caused that injury.
A brilliant answer to a maybe a little bit stupid question, but it was very provocative indeed. Yeah, because this approach of considering extrasoft therapy as a preventative method to avoid surgery or to avoid prevent from vascular necrosis is brilliant. It's brilliant. So very interesting.
I have done it in a few individuals. I've actually treated AVN at the second metatarsal head, otherwise referred to as Friedberg infarct. And I've actually seen resolution of that and full return to sport. And then unfortunately, that individual's sister fractured her femur, had ORIF, had a complication of a second fracture distal to her original ORIF, requiring revision surgery. And then she subsequently saw me for shockwave. With the idea, let's try this as a prophylaxis. And I had very clear discussion with both the surgeon and the patient, the low level of evidence for doing this. But honestly, it makes sense. Biological plausibility.
I agree. We have some time for more questions. Catherine, there is a question in the chat that maybe we can answer now. From Minadi, you are asked, any screening or diagnostic tool for Rett's? You mentioned something, but maybe you can elaborate a little bit more.
Sure. So that's the REDS CAT. So we had the relative energy deficiency in sport CAT that came out back in 2015. And it was a little bit overwhelming because it was just a list of different things to be considering: eating disorders, cardiovascular findings, changes on the EKG, decreased bone density on DEXA, all sorts of labs, all the things that I've already kind of spewed out. And so that's those are good things, but it was hard for people to decide, well, what does this mean in terms of screening for risk of injury? And what do we do with all that information? And who's really low risk and who's high risk? And then we had the triad return to play criteria. And those had fewer, but there was a point system. And so we actually did a paper comparing the two and trying to figure out, was one better than the other? And the answer was no, one wasn't really better than the other. They would be better if they could be sort of meshed. If we could have more criteria, like all the different red signs and symptoms, but we could give them a point system. So it still is uglier, to be honest, than the triad one, because there are so many different things. But we've come up with this point system where there are primary and secondary indicators, and then there are some that are emerging markers. So things that we do think are related, but we can't really give them points yet because there's not enough scientific evidence. And so we have one of the papers, and I'm sorry, I keep teasing you with and it's coming out. But one of the papers is that REDS CAT, and we tested it with different doctors around the world to see if they would get to the same scoring system and would kind of rule the same way based on their clinical acumen, and then comparing it with the REDS CAT, and it seems to be holding up pretty well. So we'll need to be doing a lot more validation studies in different populations, but I think that'll really help us, because then we don't have to always wait for somebody to have menstrual irregularity for a really long time. We don't have to modify the triad scoring system as much for the men, and we can use other markers in our toolbox.
Yeah, that's why I said at the beginning that we were very much expecting your publication of the new SCAT.
I know.
SCAT,
I'm just one
SCAT
person. I'm
correct.
working with 15 people. We got to get those papers in.
Yeah. Let's do one question for Tony, another one for Adam. Tony, what do you do when there is a kind of plateau in the progress for an athlete in the recovery time? There is something that is not going well.
I mean, I think the first thing I mentioned it earlier, that sometimes regressions are normal. So when I have someone who's kind of progressing quite well, I give them a little bit more load. The next time they come back and they complain of pain, or, I mean, on the rare occasions, swelling, those sorts of regressions don't really worry me. Like I said, we take a day or two of rest, we gradually reintroduce the load, and hopefully things continue. But in those cases where we're continuously getting worse, or maybe associated symptoms are becoming apparent. So like I mentioned, the radiating pain in a spondylolysis, then I need to really start thinking, has there been a shift? Has there been a listhesis? And I need to get them back into for a doctor's consult. And that's why it's great to work in that multidisciplinary team. I may get to spend the most amount of time with the patient, but that just means I've got the responsibility of delegating when things don't seem to be going right. So generally, these are time-consuming injuries. I'm looking at, 5, 6, 7, up to 12 weeks of rehabilitation. And as long as it's going step by step, that's fine. But as soon as things aren't going well and I've deloaded and I've removed any kind of painful stimuli, if they're still in a plateau or they're regressing, that's when I need to send them off. Maybe they need to go see Adam for some shockwave, or they need to go to the podiatrist. Maybe I haven't picked up on something in their nutrition. They need to go and see those different multidisciplinary team members. So it's great having that environment to work in.
The three of you mentioned the multidisciplinary team is key in the risk factors. And I agree with you. And this is one of the things we are trying to do in the Aspetar bone stress injury group. Tony, I'm more concerned of the backtracks than the plateaus in stress fractures. I mean, guys that start to run and they start progressing too fast, start having pain, get frustrated, or having these funny pains that are not exactly the location of the first injury or the first bone stress injury, but in the surroundings, in the vicinity. So I try to explain them, well, you have been 6, 8, 10 weeks not running, now you are coming back. This is like when you are starting a season, but it's not easy. It's not easy. We have 2 minutes. So in 1 minute, Adam, tell me, do you use teriparatide for TO, and when?
No. You can't get it covered. It's $2,000 a month. Rarely we've looked to offer that to athletes, but I am not an endocrinologist, and I have Dr. Ackerman down the street. So in those rare cases, we'll consider it. And almost always the answer I'll get from her, from others, is it's not indicated. We also need to recognize the limitations. It's $2,000 a month. It's an unstable peptide. It needs to be refrigerated. It's not going to get covered by insurance. And I would say there's a higher level of evidence for using other interventions that can be more cost effective and easier to apply, including shockwave.
Catherine, do you want to add something about that?
Yes, so it can be indicated if they have osteoporosis. So if they have really low bone density, then we can get it covered. But if they don't have osteoporosis, we no longer get free samples. So it really is a limitation. And we certainly wouldn't give it to people in immature skeletons. So that removes that option as well.
Yeah. And what about a delayed union or non-union situation?
I have only used it in patients who had osteoporosis and that's always the first benchmark.
Yeah, osteoporosis as a main condition. Great. So 6:30 here in Qatar. I think it's 9:30 in Boston. Thank you first to the audience. I think in certain moments we almost reached 70 attendees. So thank you to all of you for coming or coming along to be with us. Thank you for the organizers, Faten, mainly Sophie, because she was there on the backstage supporting everybody of us. Thank you, Sophie. Very efficient work. Thank you also, Dr. Paul Dijkstra. He's the Medical Education Director in Aspetar for making this webinar series available. So you know that now there is I think there is another one in March, and then there is a break until the end. Well, maybe he can tell you later. But anyway, pay attention to the Aspetar Wednesday webinar series. It's a very interesting action. And also for you to know, the Aspetar Bone Stress Injury Group is planning to do more activities. So we are maybe considering to have another specific webinar series only for bone stress. And then for any of you, of the people that attended, please, if you have still any question, you can still use the chat, or if any of you knows us personally or you have our email addresses, please don't hesitate to raise your question, send us your comments or your requests, and we will try to come back to you with the best of us. Thank you all. Have a nice evening for those living in Qatar or in Far East, or good morning, good day for those of you in USA. Thank you all.